Very little, if any, sensation at all. And when they freeze you completely, when they give you enough anesthetic for a cesarean section, you're comfortable, you don't feel anything at all. Okay? Now, we talked about issues with the epidural. Some people say, don't have it, you'll have back pain. I don't believe that. That's not the cause of the back pain. It's more of an issue with respect to the pushing, right? When it's time for you to push. And sometimes if you're just too frozen, you just don't have enough sensation to push effectively with the epidural in, we're going to turn the epidural off. Okay? We'll turn it down or we'll turn it off to the point where you can feel your contractions again and you can push effectively. All right? Remember I said this is about you having the baby, it's not about me having the baby. I don't want to have to drag it out. I really, really don't. I want to interfere as little as possible. Okay? If I have to, I will. But I don't want it to be because you couldn't push because you were frozen. So if you're frozen, turn the epidural off for a little while. You'll feel your contractions. If you need a little more, we'll give you a little more freezing. But I want you to push. Okay? So don't be terrified about it. When the delivery is over, we'll take the epidural catheter out. We just pull it out. Now, a couple of things about this. You can see the markings. There's a little black mark at the end. And then there are markings along here, 1, 2, 3, 4. So we know how far to put it in. And when we pull it all out, we just want to see that there's the little black marking at the end. That tells us that the whole catheter came out. In the old days is 25, 30 years ago, these catheters there were no markings, and they were a stiffer plastic, and the needle was much sharper, and once in a while as we pulled the needle out, it would cut the plastic, and a little piece of the catheter would be left in your back. And the question was, should we take it out, shouldn't we take it out? We just left it there. Today, we try not to leave things behind, and these things are much safer. The needle is not as sharp, and you can see that this is really amazingly strong. Okay? You can pull this and it just won't break. And the reason is because it's got a little wire inside it. So feel with your fingernail here, you can feel that there's a little coil, right? So there's a little wire inside it that prevents it from being cut. And we always look at it to make sure that we got it all out. All right? Fair? We talked about the risks with an epidural. Once in a while, somebody gets a spinal. All right? Once in a while, somebody gets a spinal. Once in a while, somebody gets a spinal leak and gets a headache. These are acceptable risks. You have to accept it yourself if you're going to have an epidural, and we accept them because things happen. We're not perfect. We're not perfect, and we don't claim to be perfect. Okay? We try to be as good as we can. Once in a while, somebody gets a spinal. All right? If you've got an epidural, you're comfortable. Got the morphine and you're comfortable with that, that's great. Labor along, and we're going to monitor. I brought a bunch of monitor strips. It's not so important that that we look at them, but I just photocopied a couple just to show you that this is what they look like. All right, heart rate on the top, contractions at the bottom, and you're going to be looking at this machine. I know it's in the room, and there are lights, and there's paper spitting out, and you can't help but look at this machine. So I want you to know a little bit about it, but I don't want to pretend for a moment that I'm going to teach you all there is about heart rate tracings, because it's just plain not possible, nor is it necessary. The nurses are going to be in and out, and they're going to examine you from time to time. I want you to make progress. Labor is about making progress. And progress is measured in different ways. Remember I said that progress is measured by effacement. Is the cervix thinning out? Is it thick? Is it becoming thinner? Is it now thin as paper? It's measured in descent. Is the presenting part coming down? Was it high up? Is it lower now? And it's measured in dilatation. Is the cervix opening up? She was 3 centimeters. She's now 6 centimeters. She's 8 centimeters. She's moving along. All of these things are happening at the same time. Okay? Sometimes one happens a little faster than the other. Sometimes it takes a little while for the head to come down. But I want to know that all of these things are happening. And we want to see progress. Okay? In a girl having a first baby, you should be progressing at the rate of, once you're in good labor, you should be progressing at the rate of about 1 centimeter an hour. okay? About 1 centimeter an hour. Faster in the second part, okay, because that's what the labor curve looks like. Here's the latent phase of labor. I'm not doing much. I'm getting into the early part of labor, and now I'm really booming along. And here on this part of the curve, we're really moving along quickly. We're going from 7 centimeters to 9 centimeters in maybe in 20 minutes. And a girl who's having her 3rd or 4th baby, she can go from 7 centimeters to delivered in 3 contractions. So it really moves along towards the end. You get to full dilatation, okay? And you've made normal progress. I haven't had to interfere. We didn't need to run oxytocin. You're just moving along, and we want you to push, okay? We want you to push. Okay, you haven't done this before. We're going to help you. You may have an uncontrollable urge to push, especially if you haven't had any pain relief. You're going to have, when you're fully dilated, this uncontrollable urge to push. And sometimes you'll have this urge even earlier. You know, you're 7 centimeters dilated and you feel like you want to push. At that point, we don't want you to push. If you start pushing and the cervix is not fully dilated, it's going to swell, it's going to get trapped. You got to hold off, okay, until the cervix has opened completely. And then we want you to push. And we'll check the position of the baby to see how the baby is coming down, because it doesn't always come down the way we want it to. So let's look at this. Oh, one other thing before I go into that, I promised you I would bring you the fish. Okay? For that girl who wants to go natural, doesn't want anything for pain relief, here's the fish. Okay, I'll bring it over. We'll hang it on an IV pole, and you can stare at this stupid fish and see if it takes your pain away. And if it does, great. Send it all away with the fish. But if it doesn't work, remember I said it's a fish, right? There's a reason. Okay. All right. So, position of baby. Let me just sit down here for a second. "95% of the time at term, the baby comes down head first. 4 to 5% of the time, the baby's a breech. If you can't see, I'm going to show you, don't worry. The baby's a breech. That means the head is up. And it may be coming down feet first or bum first or 1 foot or with the knees. Less than 1% of the time, the baby comes down as a transverse lie. But most of the time, the baby comes down head first. Now, when it comes down head first, it can come down in any position, right? Any of these positions. What we want the baby to do is we want that baby to come down as a flexed vertex, okay? A flexed vertex. That means the baby's head is coming down this way. Okay, if I'm that laboring patient, and here I am, and my legs are up like this, and I examine you, I want the baby to be face down. Okay? I want that baby to be face down. And I'm feeling the back part of the head. Sometimes it comes down and it's presenting with the brow. And once in a while, remember I said it'll present face first. Ugly kid. That really doesn't happen very often. The most common situation is it comes down face down. And the next most common situation is it comes down face up. And then sideways. Now, face up and face down are probably the best. Transverse can sometimes be really tricky. And hopefully, if it's coming down this way, it will convert. Because as you're pushing that baby's head down, and it hits the pelvic floor, it rotates. And most of the time, the baby's smart, and it rotates into the best possible position, which is face down. Sometimes it does the opposite, and it goes face up. And the reason that it's a problem is because when it's face down, it's presenting the smallest diameter. And I want to just show you what that means. So, Daddy, can I borrow you for a second? Come and sit down here. Just sit down. And just put your head down. When that baby is coming down in this position, this part of the head is presenting. You can see the diameter. When that baby is coming down upside down, this is presenting. And this diameter is almost 50% bigger than that one. Which one's easier? Duh. Thank you. Okay? We want that baby to be coming down in a face-down position because it's just so much easier. When it comes down in a as a malpresentation, where it's an occiput posterior, you need a big pelvis, right? Truck can go through here. Remember? Right? Sometimes it will convert. Sometimes as it comes down, it will rotate. Sometimes it won't. And sometimes I need to help. And sometimes it just gets stuck as an occiput posterior. Now the reason that those are easy is because, we're more used to putting on forceps and turning babies when they're straight. When they're sideways, when the face is turned sideways, sometimes it's a little trickier to turn them. Okay? So if I need to put forceps on, those are a little trickier. So most of the time that baby's going to come down in good position. If it comes down in good position, I'm going to work with you. I'll tell you what the position is. I can feel, when we're examining you, we can feel the bones. And we can feel from the position of the bones how the baby is coming down. And I can feel how much molding there is, because sometimes when that baby comes out, it's coming out as a little cone head, right? And the head is not nice and round. And the reason for that is because the bones are soft and they slide, they mold. Okay? They mold to fit through the pelvis. Now, that takes time. Molding takes place over hours. And when you see a baby come out with a head the size that looks like a little football, that head has been molded over a period of time. And a period of time is 10, 12, 14 hours. And it's normal. And after the baby's born, you look at it and you say, whoa, cone head. And over the next 2 or 3 days, it will go back into completely, totally normal shape, because there are no cone heads walking around. Okay? Now, as long as that takes place slowly, it's safe. If you try to change the shape of the baby's head in 15 minutes, it's a disaster, right? You're going to kill the baby. As long as it goes slowly, it's safe. And molding can sometimes, fool you when you're trying to check the position of the baby. Okay? And sometimes, when you're pushing, we can feel all of the molding, all of the caput coming down. The head is still up. All the molding is coming down first. So, all of this will depend on how well you're pushing and how, what time we examine you, and, various factors are going to be involved in all of this. So as long as you're fully dilated, the cervix is opened up, and we know the position of the baby, we're going to get you to push. Okay? If it's not in good position, we'll see if you can convert it. We'll see if good pushing and time will change that baby from a transverse lie, or maybe even a posterior, to an occiput anterior. If it doesn't, we may need to change it. We may need to interfere. But if I don't have to, I don't want to. So I'm going to let you push. And pushing is going to be hard work, right? Yes?
How would you interfere to change the baby's position?
I'm going to show you in a few minutes. Okay? I'll show you. We're going to get you, once you're fully dilated, we're going to get you to push. So we've monitored you all along. The nurses have been in and out. I may have been in and out. We'll see that you're making good progress. You're finally fully dilated. And now you're going to push. If I'm at home, the nurses are going to call me and say, your patient is ready for delivery. She's fully dilated. She's pushing. Come on in. If I'm in the hospital or in the office, they'll just tell me to come over. All right? We get you to push. He's on one side. I'm on the other side. And we close the door. Because sometimes there's a lot of yelling that takes place in that room. Sometimes it's me that's doing the yelling. Okay? And I'm screaming at you, and you're screaming at me, and he's screaming, and we're all, we're all trying to help you, right? And sometimes you say things that, you didn't really mean. And sometimes I say things too, right? That stays inside the room. Okay? Everything is fair inside that room. We want you to have that baby. We're trying to encourage you as best we can. And sometimes it's noisy in that room. You're pushing. How long will you push for? The answer is, I don't know. It's obviously going to be easier to push out a 6-pound baby than a 10-pound baby. And if you've got a big pelvis as opposed to a small pelvis, it's going to be easier. And if you're a really good pusher as opposed to a wimpy pusher, that's going to be, I got some girls who push and they go, It's not going to do it. I need some hard work here. You really got to work on this, and we're going to help you. We'll try and thin out the perineum and help you push this baby down as best we can, with or without pain relief. Okay, no pain relief. Is there going to be some noise in the room? You bet.
That's what earplugs are for. Earplugs.
It's going to hurt a little bit. If you've had an epidural, you know what? The noise is from the screaming, that's all. Just from us yelling. You push down, and the perineum, that's the part between the vagina and the rectum, thins out. And if you're a really, really, really good pusher, and you've got good elastic tissue, it'll stretch nicely. You may not need an episiotomy. You may not tear. You may not need an episiotomy. The girl that we delivered Thursday night with the twins, remember on Thursday night? 36-week twins. We delivered them spontaneously. First baby came out. Second baby, we ruptured her membranes, and she delivered it spontaneously. No forceps, no vacuum, no nothing, and no episiotomy. And we got 2 babies each around 5 pounds. Pretty good. Pretty good. No tears, no nothing. Great. Sometimes it's not like that. Sometimes you've got an 8-pound baby, or more, 9, 10. The vagina will stretch. Okay? It will stretch. It's not going to tear. It might not. But the perineum, that's the opening, right? The muscle right here at the bottom between the rectum and the vagina, is going to only stretch so far. And if you've got really good elastic tissue and you're a good pusher, you know what? You might get away without an episiotomy and it might not tear. And if that happens, that's great. I'm not going to make an episiotomy unless I have to. Okay? If I see that I need to make one, I'm going to make it. I'm not going to let you tear. Some people say, let her rip. Let her tear. It heals up better. Nonsense. When it tears, it goes wherever it wants to go. And I look at it and I say, all right, where does this fit? I don't want to do that. I want to cut it. I want it to go straight. I'm going to put it back together for you again as perfectly as I can. How long will I let you push? You know, that's hard. It depends on the kind of progress that I see. If I see that you're making progress, I'm going to work with you. If I see that you're making no progress at all, this is just not going anywhere, I'm going to have to help you. I think you agree, and I think, you know, you're going to wave a white flag and say, you know, get this over with. Help me. I want you to do this. I don't want to do it. I want you to push this baby out as best you can, and so does he. I don't want you to surrender too early, but at the same time, I need to see that you're making progress, and I can't make that decision in 15 minutes. I'm not going to know that quickly. We need to work for a little while. How long do I think is crazy? I think more than 2 hours of pushing, I think, is crazy. I think by then we're all exhausted. And at that point, I'm going to say to you, here are the options. I need to help you a little bit, okay? Sometimes all you need is an episiotomy. Sometimes you don't need that, and if I don't need to make an episiotomy, I'm not going to do it for fun. I promise you. I'm not going to cut you just because I want to. That's not something we do. If we make an episiotomy, it's because you needed it. Okay? You needed some room, so we give you a little bit more room. I see that you're going to tear. I don't want you to tear. I want to prevent these things. Now, there are some issues with respect to long-term consequences. Remember that girls have babies, guys don't. A girl's pelvis is a hernia waiting to happen. And you all know that there are women later on who complain of issues. And the biggest issue that we see today is stress incontinence. Girl is 35 years old, 45, 55, and she says, every time I cough or sneeze, I wet myself. These are almost always consequences of childbirth, and sometimes it's because it was a traumatic delivery, sometimes it's because she pushed way too long and everything just got stretched out, or she didn't heal as well as she could have, everything didn't get pulled back up. The bladder sits on top of the vagina and it gets stretched. It prolapses a little bit. Yes?
Should we be doing any Kegel exercise?
I don't know that it's going to make any difference at this stage. Will it happen? Will it help afterwards? Yes. Sure. Tightening your muscles, will it help to strengthen the vagina and support the bladder? Sure, it probably will a little bit. At this stage, would it make any difference? 0. Okay? So, the bladder takes the brunt of this. As well, the back wall of the vagina gets stretched a little bit, and so later on, there are issues with prolapse. And sometimes if you tear, if it hasn't been sewed up properly, if you've been allowed to labor for a long time, they've been big babies, multiple deliveries, there are long-term consequences. So all of this is in my mind as well when I'm thinking about letting you push and how the delivery is going to go, as to what the long-term consequences are. Should I let her push more? How is she stretching things out? What's going to happen? All right? All of these things are issues. If you're pushing and you're not making progress, you need a little bit of help. What do? Well, here are the options for you. Number 1, we said, was an episiotomy. Number 2, we have a little vacuum extractor. Okay, so this is a little handheld vacuum, and if I just put this right on your palm, and if I pump it up, you can see that it's producing some suction, right? And you pull, right? So sometimes we'll use a little vacuum, and this goes on the baby's head, right? And we create a little suction by pumping it up, and then pull. Well, first of all, we got to be able to get this in the vagina. Okay, so I mean, it's got to be at least this big, right? You're already thinking, oh my God, the baby's bigger than this. This is useful for pulling the baby down a little bit. Do we use it? We do. From time to time we use it. Do we use it a lot? I don't think so. One of the advantages is it's simple. You don't have to be a genius to use this. And the risks are pretty low, although the risks are not 0. You got to know how to use it. The disadvantage is that it has nothing to hold it on. It pops off easily. So it comes off pretty quickly. And this is kind of useless for turning a baby. So if we've got a baby that's not in good position, its head is turned sideways, or it's posterior, this is not really very useful. There's a different type of vacuum as well. Sometimes we'll use this one. Looks like a toilet plunger. Okay? We're not going to give this to you to suck on. All right? It gets hooked up to a vacuum machine, and then again, this part goes on the baby. So this has got to fit inside the vagina. So we just fold it up and push it in, and this goes against the baby's head, and this is attached to the suction, and it pulls. Is it useful? Yes. Do we use it? From time to time. Would I rather that you push the baby out? 100%. Okay? Again, fairly low risk, not 0. You got to know how hard to pull, how often to pull. You need to know how to do it. It's not for everybody. Okay? So, but is it useful? Yes. If we can't get the baby with the simple vacuum, then we're talking forceps. So I want to talk to you a little bit about forceps before we talk about anything else. Okay? If we're going to talk about forceps, now we're talking about serious stuff. So here are forceps. And these are 2 different types that I brought down. There are 3 ways to get a baby out. Number 1, you push it out. Number 2, I pull it out. Number 3, I cut it out. I want you to push the baby out. I want to do as little as possible. On the other hand, if you need help, baby's not in good position, we're kind of stuck. So forceps. And these forceps look completely different. But the part that goes on the baby's head is almost exactly the same size for these 2. Okay? The difference between these forceps is that these ones are angled, these ones are straight. And these are my favorite forceps for turning a baby that's in bad position. So if a baby is in posterior position, it's face up, and I need to turn it into face down position, these forceps help. Okay? And they go on the baby's face. All right? They go on the baby's face. And they fit here on the face, right there, between the ear and the eye. Now, you can see on an adult, there's not a lot of room between the ear and the eye. So in a baby, there's even less room. So there are some issues with respect to forceps. And the issues are, can we put them on? Can we put them on properly? Can we put them on safely? Can we do a forceps operation safely? Okay? Because we need to turn the baby into a better position. And if I can turn that baby into a better position, I can deliver it. The forceps are, they're a little bit like a lever. If you've got a 300-pound rock that you need to move, it's pretty hard for one guy, unless he's really strong, to grab that rock and to move it. If he can get 2 or 3 guys, they can move it together. It'll still be hard work. But if he goes and gets a crowbar and puts the crowbar under the rock, he can pry that rock up by himself and move it. It's just mechanical advantage, right? Now the crowbar can't be too long. If that crowbar is 20 feet long, that's not going to work. And it can't be too short. If he's just using a 1-foot crowbar, that's not going to help either. He needs a 4-foot crowbar. And it's the same thing with the forceps. If they were any longer, we would be too far away from you, and if they were any shorter, it wouldn't be effective. And over the years that forceps have been available, they've evolved into these shapes and to these sizes. This forceps goes on and locks into position. This is a perfect forceps for turning a baby. And you can see that it's angled like this. And as I turn it way out here, right, it makes a big circle out here. And at this end, it makes a very small circle. It's a cone, right? If you look at a cone, there's a tiny little circle at the tip and a big circle out here. So as I'm making a big circle out here and turning the baby's head is turning in one position, right, at the other end. So these forceps are terrific for turning a baby. These forceps are terrific for extracting a baby. And the reason they're better is because they've got a sliding lock and you can maneuver them a little bit. You can turn the baby with these ones also, but you have to put them on upside down and turn them in a flat position like this to get them to stay in one place. The other ones are easier because you can make a big circle. So sometimes we need to put on forceps to change the position of the baby. If you say to me, you can't use forceps, I'm stuck, right? Baby's not in good position. You can't push it out. I can't help you. Where are we going? We're going to the operating room. Exactly. So there are a few times where I'm going to say to you, listen, we need to do this. We need to do this. And one of the few situations where I might come to you and say, look, you haven't had an epidural. I know you don't want one. But listen, your baby's upside down. And you've been pushing and you can't, it's not coming. I need to turn the baby. And to try and turn the baby without good anesthesia, that's difficult. I could try to put in what's called a pudendal block, where we block the nerves. Sometimes that works. An epidural works better. And I might say to you at that point, have an epidural. I can put the forceps on and turn the baby. There's a good chance I can save you an operation. But if you say to me, I don't want it, I can't do it, you understand where you're going to go with this. You could end up with a cesarean, okay? So I want to talk to you now, before we go on to talk about cesarean sections, I want to talk to you a little bit about these forceps procedures. And I want to talk to you about a concept called a trial of forceps, and specifically a failed trial of forceps. Every time we put forceps on, it's a trial. It might be successful, might not. Most of the time, it's going to be successful. But from time to time, we're just not certain, right? You've got a baby that's a little bit high up, and it's an occiput posterior, and you're not sure whether you can put the forceps on, and you're just a little bit uncertain. Most of the time, I'm not. I have a really good idea before I put those forceps on whether I'm going to be successful or not. Once in a while, I'm not sure. And that's the place of a trial of forceps, because I want to bring a concept in for you. And here's the scenario. It's 2 o'clock in the morning. The operating room nurses are not here. The anesthetist is not here. You've had an epidural. Your baby is in occiput posterior position. And we go into the delivery room and we put the forceps on, or try to, And we can't deliver the baby. Either we can't get the forceps on properly, or we can't turn it. We can't deliver the baby. So what do? We take them off. And now I have to phone everybody to come in. So I'm going to call the pediatrician too, because now it's a bit of a risky situation. I'm going to call the pediatrician. I'm going to call the surgical assistant, 3 nurses for the operating room, and the anesthetist. All these people have to come in. How long is it going to take? 20 to 30 minutes, right? Another 10 to 15 minutes to set up the operating room and to get you over there. And by the time we start the cesarean section, from the time I made the phone call, is going to be about 45 minutes to an hour, right? Not a good decision. So failed forceps, you put the forceps on, you couldn't deliver the baby. Failed forceps, maybe it wasn't such a good decision. On the other hand, you could say, and what I'll often say is, listen, I need to turn the baby. We're going to go and do this in the operating room. Okay? We're going to call everybody in. Everybody will be there. I'm going to put the forceps on. We're going to try and turn the baby. And if I'm successful, it's a successful trial of labor. Everybody was called in unnecessarily. They might be a little bit mad at me, but it's the way it goes, right? The nurses are going to get paid for coming in, whether they're there for 20 minutes or whether they're there for 4 hours. They're going to get paid for 4 hours anyway, so that's not an issue. The anesthetist might be a little ticked with me for calling them unnecessarily, and the pediatrician too, and the assistant, but I don't do that very often, so it's never an issue. Because if I put the forceps on and I try to turn the baby and we're unsuccessful, it's a failed trial, we take them off and everybody's there and we can do a cesarean section in the next 10 minutes. Good decision. Okay? The trial was unsuccessful. It was a failed trial, but it was a good decision because you called everybody in. Do you understand? Yeah. Right? So sometimes we're going to do that. Once in a while, I'm not going to do the delivery in the delivery room. I'm not comfortable there, saying, you know what, I just don't know whether this is going to go. I'm going to call everybody in. We're going to do a proper trial of forceps, and we're going to do it in the operating room in case we need to do a cesarean section. All right? Cesarean sections. Big issue. In this hospital, I asked the nursing manager a couple of weeks ago what the cesarean section rate was. She said it's 34%. That's unbelievable. It's really, really high. And I'll tell you honestly, the cesarean section rate has been slowly but progressively going up everywhere. Everywhere. When I finished my training back in 1977, I don't think we had a cesarean section rate that was much more than 10 or 12%. We were delivering breeches vaginally. We deliver almost no breeches now today vaginally. We were doing mid-forceps operations. There are fewer of those. There's just less tolerance for risk. Just less tolerance for risk. We want every single delivery to be as safe as possible. We want a best possible outcome for baby, for you, and risks have just, we just don't take risks. So the cesarean section rate has gone up. And cesareans are done for all kinds of reasons. Sometimes they're done because a girl says to me, I want a cesarean. It's an elective cesarean. Will I do that? I will. I'll try and talk her out of it. But I'm not going to beat her over the head, and I'm not going to persist with this. If a girl says to me, listen, I just don't want to deliver vaginally, can she have a cesarean section? The answer to that is, yes, she can. Okay? I don't want you to think for a moment that in my practice, that doesn't happen. Once in a while it does. Most girls don't say that, but sometimes it happens. Most of the time, cesarean sections are done for a reason. You're laboring along, everything is okay, there are no problems, and then you fall off a cliff. Something happened, we need to interfere quickly. Girl comes in, she's in labor, everything is going along, and all of a sudden you see the heart rate go down, or there's a concern for some other reason, and you do an internal examination, and the cord is there. The cord is prolapsed. She's 5 centimeters dilated, and it's a breech. There's a foot sticking out. There are all kinds of reasons. Sometimes we don't like the tracing. Sometimes it's just failure to progress. You're in good labor, the baby's in good position, and 4 hours later, despite good labor, you're nowhere. you're still 4 centimeters dilated. You're 5 centimeters dilated. You were 4 centimeters at 8 o'clock and it's now midnight and you're 5 centimeters. You made a centimeter an hour and we say, ah, this is creeping along. We need you to make progress, okay? We need you to make progress. And as long as you're having good contractions, you're in good labor, and you're making no progress, right? That white flag is out. It's saying, I surrender. So there are lots of reasons for cesarean sections. Big baby, diabetes, high risk, small baby, growth retarded babies. There are all kinds, growth restricted babies, all kinds of reasons for cesarean sections. Everybody knows someone who's had a cesarean section. We did 3 of them yesterday. We talked about it earlier. If we're going to do a cesarean section, here are the rules. Number 1, it's done in the operating room. Number 2, your husband can come in as long as you're awake. And we put almost no one asleep now. Almost all cesarean sections are done under spinal or under epidural. Okay, so your husband can come in. He's there to keep you company. He's not there to keep me company. He's not going to assist at